We've now got a plenary session, which will be led by Carol Bond, and we will be discussing empowering patients and staff. So please welcome Carol.
We've just had a round table meeting looking at what we think some of the issues are. I'm going to run through our list very quickly, but the main aim of this session is to get a much more interesting debate going with the panel and everyone sitting round. So as soon as I've finished, we'd like to invite questions, comments, points of view, anything pertinent to discussion. All I would ask is there's a roving mic going round, so if you want to speak, please raise your hand in the traditional manner and wait till the roving mic gets round to you so that everybody in the room can hear. The points that we looked at, we did touch a little bit on technology. We talked about the importance of APIs and the possibility of having innovation centres like the Chinese Schengen area, where we could actually encourage things without the constraints we normally have. But a lot of the things really came round to culture and how people behave rather than the actual development of the technology. We looked at how we move from silos to networks and how we move from being reactive to predictive and from working in silos to sharing. We looked at how professionals and patients both need to change cultures and how important the relationship between those healthcare professionals and patients were going to be. And we talked about self-maintenance and self-management and patient information needs, straying into the concept of, is there such a thing as too much information? And then we looked at some of the barriers around in resource management, in governance. We weren't asked to look at solutions, but I'm sure that that's going to be coming up as a big issue. But the panel would welcome developing the discussions further with you all. While people think of their questions, perhaps I could invite the panel to say one or two words about the things that interest them most.
Want me to kick off? One of the most interesting questions, I think, that came out of the roundtable discussion that I was sitting on is something I hadn't really thought about, which is when you empower people to manage their own conditions more and care more in the community, trying to understand. We were talking about the sort of professional-patient relationship. Very interesting discussion about how do you resource manage? How do you know? If you empower patients to be more demanding and pushy in terms of what they do and how you do this, how do you then reflect that back on a service which is stretched? How does the physician know exactly how to sort of titrate this sort of attention? Is there a possibility that we actually make things worse by effectively putting people on the system that's already available to some degree? So I don't know if there are any professionals out there that have any views on that.
Would somebody else like to comment? We're still not getting thoughts from the floor yet.
I will follow. We had a very good conversation at our table, and in the interest of my self-declared interest, I will not talk about the API side of that conversation. To me, the most interesting part of the conversation was to what extent are we treating patients or service users formally versus informally? To what extent do people bring in loved ones or advisors or help? Who are you really treating? Are you treating the individual, or are you treating or servicing their support structure? And a critical subset of this is, what's the temperament or the predisposition of those people? Do they want to follow the physician's advice, or do they wish to engage with the physician and the care team? And I think it's a very significant challenge, because clearly we can allocate our resources more efficiently and effectively if we have a better understanding as to A, the expectations, and be the desires of our service user patients and the people who they bring in with them to aid them in the course of either an acute treatment or outcomes or chronic circumstances.
Well, looking at the title of Empowering Patients and Staff, I want to focus on empowering staff, or more importantly, perhaps disempowering staff. When you have rules of governance over data or data entry over the healthcare IT, and those rules are not responsive to the actual reality of what clinicians have to do or what makes sense for the mission of the organization, what constantly happens is you create frustrations and rage by the staff. And unless you create software systems that are responsive to the actual needs, then you're just going to create a series of learned helplessness that becomes pandemic. And people begin to give up, and they work up brilliant workarounds because clinicians care about their patients. And those workarounds are sometimes very efficacious, and very often they're dangerous as all hell. And what we need to do desperately is to listen to the staff and their needs, which, by the way, are always emerging and always changing in relation to the needs of patients, to the new technologies, to new drugs that are out there. And we need to listen constantly and then modify the system in ways that make sense. The second you set it and freeze it, it's lethal. Similarly, the second you allow the technology to drive the needs of patients and their clinicians, you're going to screw up badly, because the system should be responsive to the mission of the organization and not responsive to dead code put into the software by people who don't know anything about patients or clinical life.
Got a question from the audience.
Hamish Lane, Medical Director, ABM, University Health Board here in Wales. Just to pick up the previous point, I think patients are not homogenous. There are some who are keen to be empowered, they're keen to have information, they're keen to very much engage and direct their care. And at the moment, there are a significant majority who still accept, or indeed perhaps even prefer, the rather patriarchal system that we have. I think what's interesting is that as we empower patients by sharing information with them, and we co-produce the care we provide, the role of the health professional is changing, or will need to change, from one who is the owner of information to one who interprets information. Patients come to our clinics now with an iPhone with 6 months of their own personal physiology on it, and they go, that's me, doctor. Tell me now what I should do. And it's a very different dynamic, and I don't think yet in the NHS we've grasped that, and we don't understand how we will deal with this tsunami of information. We've gone from a dearth of information to huge amounts of data about patients that we have to interpret for them and then make sensible decisions with them.
If I can follow that, I think that characterizes things very, very well. One of the real challenges we have, and I'm now speaking purely from an American perspective, you do have the circumstance of people bringing in on their iPad or their tablet or their mobile phone months worth of information, and sometimes the doctor is even prepared to engage on that, but you cannot have a serious conversation about 4 months of data in a 15 to 20 minute session. You can't have hour-long, it's inefficient. And so I think one of the real challenges, it depends on what you mean by inefficient, but I think one of the real challenges is you're dealing with larger and larger quantities of data, a desire to really engage around that data, but constraints of time and intensity. Is there going to be the equivalent of para-hospitalists or para-information people who the doctor hands off to? Are there other mechanisms where one can have these exchanges, meaningful exchanges, where the doctor or the physician or the most expensive bit of human capital in your kit are not disproportionately involved. If there's a single criticism I would argue that hospitals fail on externally, it's they don't do enough use cases of these kinds of circumstances. No, the technology shouldn't be the driver, but it is a fact, not an opinion, that if only 10 or 15% of your people bring a lot of information to discuss with the doctor, you're either going to have to be rude and cut them off, or you're going to be late and inefficient. So how do we deal with those sorts of use cases? And I hope that one of the takeaways of an event like this is that people become a little more innovative about the use cases of touch points, not just about technology.
Terry.
Yeah, we had an interesting, Hamish was on our table earlier on, and we had an interesting discussion, which kept, unfortunately, despite Lars' best attempts, sort of veering off course. But I thought one of the interesting things that came out was the way in which industry tries to stratify customers in order to meet their needs. So the person who wants to come and talk about everything, and the person who just wants to be told what to do. And the question is really how in healthcare we're going to stratify people effectively around the different types of behaviors. Another theme that came out was being more predictive, and of course the thing about a smart patient or a well-informed patient is that when they come in with all that data, they probably don't want to go over it all. They want to talk about the exceptions because they know what they're expecting to come up with at that stage. And I think this idea of stratification plus exception management is the way in which industry tries to manage enormous complexity and tries to give a lot of people an experience which is roughly tailored to their needs. And I think that was quite an interesting sort of discussion. We didn't sort of finish it or close it down in any way, but I thought that there were some interesting ideas there around what the future of patient engagement might look like. You clearly cannot personalize down to each individual person and give them all the time that they want or whatever. But the question is, can we create a series of strata in which an individual patient might find themselves more at home in one stratum than another? So there were some ideas that I thought were quite interesting that came out across the discussion.
But we have to be careful about creating a system that treats the worried well. The worried well and the articulate worried well should not be the dominant force. In fact, they're the least needy patients.
Yeah, I mean, the question is well made, and it also came up on our table in the roundtable discussion as well. We had a lot of back and forth around these issues of what empowerment means from both the patient and the staff side, and how different people might have different perceptions. And I think, although we never used the phrase, I think we had a lot of discussion around the idea that often when institutions and organisations such as the NHS in England and in other countries look at these issues, they try and take a one-size-fits-all approach. And we know, and I think, the point Terry was just making about different strata and subgroups is the way in which we have to address these things, because we also said within our discussion, we could all give examples of people and patients and family members we know who come along to a consultation with a health professional and they're just, well, you make the decision, you tell me what to do, doctor or nurse or GP or whatever, and I'll go along with it. And at the other end of the spectrum, we have patients and citizens running their own healthcare, collecting lots of quantified self-data, who want to bring it along and who want to have the lead in making those decisions. And I'll just say, for those of you who think I'm not paying attention, I'm trying to multitask here and both say something coherent, think, and tweet some of the responses at the same time. So if you see me doing this, I am actually tweeting.
Hopefully you're not alone in tweeting. Hopefully there's some other twits around.
Yeah.
Hello everybody, I'm Harri Mansikkamäki from a company called Lead-In. We are a user experience and service design agency helping companies to provide better services. I couldn't agree more of many of the speeches, including the keynote, that really the most important piece of the whole system is the end user, whether it's patient or nurse or doctor or so on. And I think that having having the views that you have shared is very good thing. But in addition to that, I would like to bring additional topic for your afternoon discussions is that when thinking not only of the care, i.e. meeting the doctor and so on, but people who are forced to be in the wards due to some whatever reason, and they are there, I think many of us agree that those places are not maybe the best stimulating places for the patients. They are optimized for the care, and that's how it needs to be, so for the nurses and doctors. But I think that engagement could be coming also through the patients who are there. They are lying on a bed, staring the ceiling most of the time and so on, maybe unable to move or restricted in the moving. So how could those people be engaged into the, I would say, mini community of the ward so that they feel more home in there, they are maybe more connected between the staff and themselves, as well as maybe their cared ones outside of their relatives and so on. I have some ideas, but it's too lengthy to share in here, but maybe something you can take on the table in the afternoon.
Any views?
Yeah, it's a great point, and I think the whole issue of how you connect people, I mean, again, you can easily fall into the trap of focusing on the technology, but the point is actually that people are no longer islands. And if they're in a ward or even if they're in the community, there are ways that they can communicate. So it's a question of how you enable that, what are the right kind of forums for that to happen. I guess it's patient-to-patient networks. Those kind of things are really important to kind of drive those. You know, how do we do that? How do we empower people to do that? I mean, I look at some of the things that happen with some of the voluntary sector groups or the patients like me type approach. I think there is clearly a popular movement around that, and that is not going to, that's an increasing trend. It's a network effect, like you said. And how do we engage with that for the greater good? I think it's really a key question. I think that's very much the topic of your introductory speech.
I think one of the great ironies or paradoxes about being ill is that the person who has the most time often does the least to support themselves. There's the fewest tools, really, to help those people. And I think if you were trying to design it, given the fact that both wellness and illness are really sort of knowledge states rather than anything else most of the time, how would you try and create tools that would help people to use the time that they have, the thinking time and other things, more productively in terms of their own future? And I think we probably haven't really sat down to produce the sorts of systems that would enable people to control their world better from where they are. We did talk a little bit about the use of simulation and modeling, perhaps, in a patient context. I'm representing the Cumberland Initiative, at Cumberland I, for the tweeters. And one of the things that we're really keen on doing is seeing the way in which simulation and modeling might work. And I think one of the fun things would be to put models back into the hands of patients. So you've spent a time, you've had a spell, an episode or whatever of care in the system. Why not put the model back to people and say, how would you like this to have gone? You know, you've done your dialysis or whatever. How would you like it to have been structured? And get people to change the system around. Press a button, and then you can have a discussion. You know, well done, this would save £20 a visit, or this would cost us an extra £2,000 a patient every year. And then have a discussion, a more grown-up discussion, around what really mattered in that pathway, why you wanted it changed that way, and getting people to engage at a completely different level. But I don't think we're using the neurons of patients, particularly while they're in the system, to best effect. And I think there's a lot could be done to sort of turn that paradox around. So I think it's a really interesting sort of set of suggestions that you've put forward there.
I think we're just going to give them an iPad, you know? And I'm being absolutely serious. For patients who are, I do not view lying in a hospital bed as being a cognitive or intellectual state. I prefer being left alone. But in terms of being engaged or distracted, yes. If I'm bored on an airline, I can watch a movie. The whole notion of what do you do with people who are moving in and out of a pain state or conscious, that's a very interesting area. That's a very, very interesting area. And one of my immediate reactions would be, that's exactly the sort of thing I would like to test in a gerontological ward and in a pediatric ward, and communicate with the caregivers in that regard and see, are we better off giving the caregiver a device or the care receiver a device and see what generates the better outcomes.
Interestingly, one of my PhD students did look at what patients wanted in the hospital environment. And the one thing that surprised us in the results is they wanted to be able to hook their iPads up to a wireless network that wasn't there for them. And that was a really important priority for them. Sorry, Ross.
Well, but remember that the people your students spoke with were the ones who could communicate. Most patients in a hospital are sick, are very old, have multiple comorbidity issues, major organ system problems, and being very sick makes you a little crazy. Most people in the hospital who your students could not speak with were basically trying to stay alive. And the fact that they were on 13 or 14 other medications probably didn't help that necessarily. So we can't romanticize these idle patients, and we have to recognize that the vast majority are just struggling.
So just a very quick note on that. And we ran a thing called a health tech challenge here about 2-3 years ago, where essentially we did a sort of a crowdsourcing of professionals. We asked them, is there something that you wish you had in terms of technology? And then we put it out there for people to do. And interesting now it's being done with patients here in Wales as well. But the thing that made the biggest difference in terms of impact looking back was just handing an iPad to people that were waiting in the orthopedic clinics to do immediate patient-reported outcomes. Low-tech solution, very simple.
Terry, I'll just let you come in and then I've got somebody in the audience.
Okay, I understand a bit about romanticizing patients, and I'm not trying to do that, right? What I am trying to do is to say that I think, first of all, I think we all value, probably more than the system values at the moment, a sense of self-determination. And that's often taken away as soon as you're in any kind of healthcare environment. Secondly, healthcare is the only system I know where important decisions are made on the basis of very short engagements of people who've got almost no preparation or preparation time for those engagements. If you're running a big project, you would have phase reviews where lots of documentation is prepared ahead of time. People have a time to prepare. A lot of stuff is done on the fly in a consultation. Even if it's a multidisciplinary team, people come together very quickly. Now, a lot of that pre-processing could be done by the people to whom it matters most. And I think there are ways in which you could, I think, give people better communication from ordering, the drink or something that they want when they're disempowered that way, all the way up to doing some thinking through. I've got 3 or 4 really big options here. Which ones really matter to me? What am I prepared to trade away for what I want? That kind of stuff, I think there's very little ways of doing that. I think an iPad is part of the solution, but I think you need the right apps on it to enable people to interact in the most useful way. A bit radical, but I don't think it has to be a romance.
I love the discussion, and I'd like to ask each of the 6 people on the panel a simple question, and while I tell you what the question is and why I think iPads isn't the answer, I want you to think of the simple answer to the question. We all agree that healthcare is a vexing problem, and we need solutions, but I think capitalism has messed with our mind, and the vendors are selling solutions like iPads, which we love and covet, and yes, I would like an iPad too, but I'm not convinced they will solve the problems in healthcare. How do we know which is best? And the answer is you don't know whether an iPad's better than a Samsung or whatever for what you're trying to do. And if we don't know which is best, vendors can get away with selling us rubbish and there'll be no improvement. So how can we know how to improve healthcare? For instance, what I would do is I'd get every vendor to tell us the percentage of staff they have who are on life support. Because if the answer is 0, none of them are relying on their own products. And until they take care in their products, they're all going to be rubbish. So the question is, what is the best way of improving healthcare? And I think the answer isn't buying a solution like the cloud, data warehouses, all of this. That is engineering stuff that capitalists want to sell us. What actually will help patients in healthcare?
So the question is the best way of improving healthcare in 1 minute.
Without falling for the trap of keeping vendors in business, we want to improve healthcare.
Who'd like to take that one on?
Sure. I appreciate the generosity of a minute. I'll use the cheaper word than stratification. The best way to improve, in my opinion, my professional opinion, the best way to improve the quality of healthcare is to facilitate informed consent. That requires that you know enough about the patient or the service user to give them something that is useful. I believe, whether one is in great pain or not, that improving, to use a military phrase, improving situational awareness is the essential first step to improving quality of healthcare. Unfortunately, a disproportionate number of people, I would go so far to say a majority, are oftentimes confused rather than clear about what their situation is when they enter in a hospital environment. I am an exceptionally well-educated, high-energy person, and it is astonishing to me how ignorant I am kept, or what kind of information asymmetries I have imposed on me when I am in a quote-unquote caregiving environment. Improve my situational awareness. It doesn't matter whether you're very smart, very average, or just trying to get by. Improve people's awareness. That will make them, in my opinion, more accepting of what might need to happen next.
So I think I don't think there's a single simple answer. I think there are several things, and I think you have to believe in quality improvement science in the way that it's done. But you also have to have a different sort of dialogue with more people. So it's the accumulation of the knowledge, which comes through the partnership between the professional and the patient, that I think is the answer. And finding a way of it not being a one-to-one dialogue, but it actually being a collective dialogue around different things. I think that's the key.
I remember once I was chatting to somebody who the challenge he had in hospital was to work out whether the person who was lying in the bed was conscious in any way or not. And so he would come along, they'd show videos, they'd have panels that you might flap if you liked the video or whatever, trying to work out what was happening. And one of the things he said to me that really stuck with me was, he said, once you can communicate, you can change the world. Okay, once there's a way out of where you are, once you can make that communication work, you can start to change things. And so I think the question is not what technology, it's what are we trying to do? How are we trying to help people to communicate? And most of the time, we're not actually trying to answer that question. We're not trying to address it at all. And so for me, I think what we need to be moving towards is a more communication-oriented agenda where we're trying to, once people can talk, they can start to say things, they can start to ask for information, they can start to pull it down, they can start to work out what their peers think or whatever, they can establish peer groups and stuff like that. And I think that this whole dimension of the sort of the communicating network is very much missing from our concept of care. Now, there are times when you don't communicate. You know, you're in A&E, you're being resuscitated. You just want somebody who's really good at doing whatever solving the medical problem. You will move through that to a time when you will care deeply and intensely about how you're going to plan for when you go home and who you're going to talk to and stuff like that. And so I think working out how we parse the communication agenda into a time to talk and a time to not talk and stuff like that, that to me is the really interesting thing. I think the technology will then follow, and whatever platform you have, it will probably be able to do the communication once we start demanding that kind of communication agenda from it.
Well,
when people enter a hospital, the probability that the diagnosis is correct is about 60%. Now, by the time they leave, the probability that the diagnosis is correct is about 95 or somewhat lower than that percent. So communicating with the patient when they enter the hospital is going to be very often wrong. In addition, remember that medicine is uniquely messy. All of the metaphors that come from airplanes or industrial development fail with healthcare.
Not if you fly Ryanair.
Patients have comorbidities. They're on a massive number of drugs. There is no manual for people, unlike an airplane. or an industrial process. The problem with the patients is unclear even to the world's greatest minds who have spent years in training. We don't know what's wrong with them. We think we're getting at it. We use successive tests, some of which are reactive and agonizing. And it's always messy and always emerging. So the idea that we can prepare in advance is wonderful, but it's problematic when it comes to real live human beings.
But there's not a single thing that you said that I disagree with, but I would like to connect it to the situational awareness aspect. The reality is, and it's one of the things I find disconcerting to the point of insulting, when the nurse and the doctor don't know, because it's a messy situation, I think it is their professional duty and obligation to say, we don't know yet.
To you,
To me,
but there are other patients who
to
would
my
find
chi-
that
to a
terrifying.
child, sorry?
There are other patients who would find that terrifying.
And that's why situational awareness and segmentation and stratification is key. And that to me is a professional obligation to, as quickly as possible, you say in the same way there's a 60% initial in a Bayesian sense of the diagnosis being corrected at the beginning. Let's take that 60% diagnosing whether the patient wants to be more situationally aware or will live in or would prefer not to know. Let's make at least that kind of commitment for exactly the reasons that you've accurately, in my opinion, accurately enumerated upon.
But I just point out that we have to remove from that equation the number of patients who are too sick to care or understand, comatose, 99 years old, 2 years old, the whole bit. There's a lot of patients who can't do any of this.
I can't disagree with that.
So something just one very quick point. It's just an anecdote of something that kind of happened to me that stuck with me for a long time. So I was clearing out, my father passed away about 10 years ago. I was clearing out his library and I found a really fascinating book. It was written in 1960. The American Academy of Sciences had pulled together the top scientists that it could find, was trying to predict what it'd be like 50 years later. So picking it up in 2010 and actually reading it, you can see that all their predictions on the hard sciences and engineering were almost completely correct. Mobile communication was predicted, the internet was predicted, the computer was predicted, all of that. You go to the life sciences and medicine section, it's completely wrong. We would have cured cancer. Basically, we'd be genetically modifying ourselves completely in terms that we wouldn't have diseases anymore. So all of these things were predicted. None of them actually happened. So there's something fundamentally different about medicine and life sciences that makes it more in the realms of, as you say, modeling and statistics. It's not something that's so easy to predict from the bottom up. And I think the sort of genome drug story is a very good example of that. It really isn't that predictable.
Terry, then I'll come to Peter.
No.
As the last one who hasn't spoken in answer to your question, I'll just try and give a very quick response. And I was thinking about my response before Mark said what he said. My initial response to your question is, I don't know. I've spent 30 years as a healthcare professional working in clinical areas, in academia and so on and so forth. And I don't know. I think, healthcare and the treatment of illness, which is what we spend most of the money on, is not easy, it's not simple, it's very messy. It doesn't lend itself easily to simple technological solutions. So I think whatever way in which we try and improve healthcare, maintenance of health, promotion of health, is not going to be technology driven, is not going to be driven by a few vendors. I mean, I've lost track of the number of times I've been to big healthcare exhibitions. You think of the HC series here in the UK, HIMSS in the States and elsewhere. And you go around and there's just so much smoke and mirrors of vendors trying to sell you what they want to sell you, which will not necessarily address your problem and issue and solve it. And I think what we have to, again, going back to the roundtable discussions we had, I think what a lot of people said overtly and not so overtly is the technology is not going to be the solution. You look at the systems of care, the way in which care is delivered, and then try and come up with an answer. Okay, what might be the best technologies to actually do that? And it might be things that we don't initially think of that are not developed with that end in mind. And I think my final point is And what we all know, anybody who's worked in healthcare knows, the vast majority of healthcare is not delivered in hospitals, but we spend most of our money on buying big, expensive technological solutions to use in hospitals. And perhaps we should look more at ways in which of keeping people out of hospitals, which might, for those who are driven by the finance, be a better, more cost-effective solution at the end of the day.
It's precisely because I'm not in the healthcare business or a vendor that I could give the immediate answer that I did. I'm a consumer, so I'm concerned what's best for people who utilize healthcare services. Vendors and deliverers have different priorities.
Sorry.
I have a feeling that one thing that would really help is if in all this information sharing, the input from the patient was considered to be as important as the various other inputs that people had. At the moment, it quite often feels as though the patient's voice is lost, even though they're the ones who know their own bodies possibly better than the doctors, unless they're the one who's unconscious in an A&E being resuscitated. I think I saw the microphone move again. Thank you.
Hi, Martin Heaven. I work with the FAR Institute and large health data sets at Swansea. I think one of the things we noticed working with health data sets is we don't have any outcome data sets. And actually, I think what we could get a lot of value from is retrospective views of patients about how they felt the outcome of what we did to them in healthcare, how that worked. So possibly a way of empowering patients is to create an app that allows a patient to give feedback after the event, which can be linked to their health data, so we can see this is what we did to all these patients and this is what they felt about it. And actually we could then start to say, well, doing that doesn't appear to work for that group of patients, but it does work for this other group.
That is, number one, you should know about Weinberg's work in Dartmouth on outcomes for medical procedures. But I will tell you, and I say this as a guy whose brother works at Facebook, what you are saying is already going on, in that there are now researchers at MIT and at Stanford and Carnegie Mellon, and I believe Imperial, who look at people who have tweeted or blogged or otherwise use social media to communicate about their procedures, and then you track with sentiment analysis their health and how they report their health 6 months, a year, 2 years later, and use with the aggregation of people what the propensities are. You establish your Bayesian posteriors, that sort of way. So what you are describing is going on indirectly, even as we speak. Whether or not it finds its way back into the formal medical system remains to be seen. But the scenario that you described is now being scraped off of social media right now.
I think the other thing that's interesting, we always want to look back, and one of the big changes that I personally would love to see is to move from sort of reactive to predictive. And one of the really interesting things to do would be to ask patients, what do you want to be doing in a month's time, in 6 months' time, and to track those things, because we are also changeable. We get a month out of it, and everything that we said we wanted, we've got, but we're unhappy because, I don't know, something else has happened. And so we say, you know, how bad it is. And I think one of the really interesting things is to try and move the accent every time towards what's going to happen. I would love to have GPs predicting what their use of A&E was going to be for the following 10 days every Friday night. And to begin with, it would be quite poor, the predictions, but ultimately it would facilitate a completely different dialogue between primary and secondary care. I think for patients, you know, they've got a few minutes when they come into A&E, most of them, they're hanging around for 2 or 3 hours. Ask them, what are you expecting out of this? You know, what do you want to get? And it seems to me that moving away from looking back to looking forward would be one of the most profound changes for patients, for healthcare systems, and for other people. And we have the tools to do it, and most industries rely upon those tools every single day.
And not an expensive thing to ask.
No, that's right. Yeah.
Anybody else on that?
I think there are 1 or 2 more questions coming up at the back. Yeah.
We have I just love what you said.
Thank you.
Terry.
Hello, my name is Rudian Hill. I'm a consultant urologist. I'm aware that I'm in the minority being a clinician in this environment, which is a shame. There's a poster in NWIS which says that every day in the NHS in Wales there are 27,000 nurses, 16,000 admin staff and 5,500 doctors. How are you going to empower them to improve care? Because I think there's a lack in engagement, collecting the knowledge base that they have, collating that feedback to make change to improve care. Would you like to make some comments on that?
Well, I'll take that. The first thing is we have to be sensitive to the technology that we put in front of them that is so often non-responsive. Choices in menus that make no sense. Do you walk to work or carry your lunch? You know, does the patient have an infection or a fever? Duh. So often we present the technology in ways that were convenient for a programmer who did not understand. And so we have to make their lives better that way. And then we have to recognize the proportion of patients who are not compliant with anything they say and get other people to help them with that. That is certainly a role for paraprofessionals dealing with that. I do worry that we will inundate either the paraprofessionals or the professionals with every thought that a patient has. That's awfully overwhelming. And unless we can somehow reduce that down to a meaningful presentation, all we will do is cause people to read nonsense, page after page.
I'll pick that one up. I think it's a really excellent point. I think it did come up a little bit in our round table, and it came up in a slightly different way to the way you phrased it, but it's the same, I think, in the same direction, which is where is the space for where this innovation happens in a system that's under pressure all the time? Where do people take ideas, and where does the collective knowledge actually get aggregated from the professional bodies, and where does the system innovation happen in such a way that it can then be adopted and spread across the NHS as a whole? Currently, it seems there are very few places where that can happen. In a system that's constantly under pressure, it's very difficult to bring those innovations in. And so that's something we did talk about. I don't say we came up with a solution, but it is certainly recognized as an issue.
I think there's a certain, if you'll forgive me, physician heal thyself question that has to be asked, which is when you talk about that community, if I were doing research or work with that community, I would be sitting people down and asking, how do you want to improve? What kind of contributions do you want to make? And when I've done versions of that in various industries, usually people want to do their jobs better because they don't think in terms of adding new value, they think in terms of optimization rather than innovation. And so the question, I think, this ironically goes back to our culture issues. Do we want systems where the expectation when you join the healthcare service is not that you're just going to be using technology to do your jobs better, you're going to be contributing and creating new value. You're going to be helping a team write an app or analyzing data or creating an engagement in the waiting room to answer those kinds of prospective questions. I think that's where we have to, that's where, when I've worked with organizations, you begin, which is how do people want to improve? Not what improvements do you seek to impose upon them exogenously, endogenously, how do they wish to improve?
I think part of the answer lies in playing more. We learn so much when we play, and I don't think, I forget who it was that said that the British treat their work like play and their play like war. And I think at times we're not managing to get that sort of balance in terms of finding time to explore stuff. That's why in the Cumberland Initiative we're so keen on using models to allow different communities to come together and to explore spaces. Personally, I think that the medical community is a community that if it gets excited about the right things can change this world. I think they need spaces where they can go and play around with stuff, where they can try, to have consultant front of house for A&E and then consultants in other places, And I think by playing around, one can then take some of those lessons back. So for me, it's finding the spaces where you can play with the right communities And I think the clinical community is very well placed to do that. Relax a little bit, have a bit more fun in terms of finding out about all kinds of exciting things that could really change your world. And I'd certainly like to chat to you afterwards.
Hard to disagree, but I'd point out that Henry Ford said if you asked people what they wanted, they would have said a faster horse. And Steve Jobs once said, what the hell do people know about the technology that we're developing? There is a limitation by people in the field that although it's essential that we do everything said, you have to recognize that people can't envision the sort of technological breakthroughs. And also, think about the cultural preparation we needed for smartphones or iPads or anything like that. The answer is zero. The tools were so much fun and so obviously effective that we used them. Even though I'm a sociologist, very much worry when we say what we need is cultural change. I think very little cultural change was needed for a lot of the things that are so popular because they were just good ideas or they worked.
Gentleman at the back.
Hello guys, my name is Akil. So we've established that patients need more say. I believe there's a space for that as well, because you said they need a space. So I believe the space is in that innovation hub that the UK is trying to get going in between NHS England innovation and Wales innovation. So what do you guys think would be the protocol or the way of actually integrating patients into those design decisions and those designs of innovation to actually make it work for them and reduce the friction of adoption? Because as you were just saying, you need a cultural shift. If they're a part of the design, it reduces the need for as much as a cultural shift in the innovation. Am I making sense? And do you guys understand what I'm trying to say? What principle do you think needs to be put in place to get these guys on board on the innovation track? Yeah? No?
I think I understand the question. So you're talking about user and user-led design and how to get user input into design, right? So I think there's lots of things that can be done there, and we're running some pilots at the moment trying to push out to patients and carers to bring back ideas and to use design companies effectively to do that. So I think it can be done. I think the more challenging thing is what are the sort of social and cooperative models that need to evolve around that. So when you're starting to create new things and you're interacting, say, with businesses that are doing that, what's the bond between those and the creation of those ideas and the things taking you forward? And I think there's a really interesting interface there which we need to look at, which is, I've seen, for example, one of the things that happened in England is the destruction of the social care system by the health service, effectively no longer looked after by the NHS at all. And that created a huge amount of innovation in social models about how you deliver care. So, community interest companies, social enterprises, all of those kind of things is a whole area of innovation that I think we need to explore. So I think the whole issue of user-led design for me is also kind of wrapped up in that. What are the new models going forward? I don't think we have them yet. I think we need to create them.
Another question? Thank you.
Yep.
Testing.
It's technology, you see, I can't handle it. It's Greg Smart. So it seems to me that healthcare delivery is a very procedural experience. It's a world of standing operating procedures and metrics and targets. And I wonder what we can do to enable and empower staff to be more creative and to have more autonomy, and how that would help to improve healthcare delivery.
So people, especially clinicians who care about this, are natural innovators and natural experimenters. And it's the nature of human nature to want to muck about with what you're doing and make it better. It's the unique power of very bad bureaucracies and bad technology that we kill that innovation and we don't appreciate it and we don't encourage it in ways that are so wonderful. So the solution has to be that we need to open up the system to people's innovations to recognize that every workaround, which are pandemic, is a signal of a problem that needs to be addressed not by the other people coming up with more workarounds, but by the system itself.
I think that we say we want to innovate more. I think there are times when you want to innovate more, and there's times when you want it to be dead boring. There are times when you really do want to go to sleep on the operating theatre and wake up again. There are times when you don't want maybe 2 weeks of frantic recovery in ITU or whatever, right? So there are times when I think it's appropriate to try and standardize and to make things happen. And I think that there's, we were talking on our table, in fact, about the fact that if you have an angiogram, some people go in through the arm, some people go in through the groin. It's two completely different sets of equipment have to be kept there. As a patient, you don't know how to be prepared because you don't know which doctor you're going to see. That kind of standardization, I actually think you should try and make it more boring. Yeah. I think that technology should make certain aspects of life very boring. When I drove here, I set the speed control to 70 miles an hour, and then that's boring, right? Okay, and I want it to be boring, and I got here safely and all the rest. What you really want, I think, is to find the points at which human judgment makes a really big difference, and you want to create as much extra time for that human judgment to be free and to be effective in doing things. So I think it's not that we want more innovation all over the place. It's not that we want more standardized procedures. It's that we want to have some kind of a grammar that separates what should become safe and boring and reliably done, and where there should be time for judgment and for the engagement of the individual, and indeed for creativity. And managing creativity to develop new pathways inside a standardized process is one of the most difficult things that we know how to do. And in most industries, it's resulted in a lot of destruction before we've finally gotten to where we are now. And that's the big challenge for healthcare, is to find a way to manage these things without destroying huge swathes of the system as it exists.
The revolution that I've been living through, and most of the people in IT here who have lived through over the last 15 to 20 years, is not just a technological revolution. When I studied computer science and was writing code, writing software, you wrote to a list of requirements. You spent time, you gathered a list of requirements. Now, with Agile, with XP, I won't say now, I'd say in the last decade, the use case rather than the requirement has become the unit of analysis. So when we talk about innovation that makes a difference and encouraging staff, let's not gather up requirements. Let's gather up those use cases and collaborate around, are these the ones that make a difference? Are these the ones to standardize, or are these the ones where there are real opportunities for new value creation? We need to spend attention to the units of analysis that matter for investment in innovation and other things.
That's a lovely note on which to finish. I've remembered that I forgot to introduce the panel at the beginning, so I'll go back to the good old Dad's Army way of doing it and say, you have been watching. Michael Craig, Terry Young, Peter Murray, Ross Koppel, and Lars Sundström. And I'm sure we'd like to thank them for their input.